Basic disaster life support. Session 4, Lesson 8, Biologic disasters. Objectives. Describe 6 key factors that compose the chain of infections. Identify clinical and epidemiologic clues suggestive of a biologic disaster. Discuss actions that can be taken to protect the health, safety, and security of responders and affected population in a biologic disaster. Describe essential infection control strategies to prevent the spread of biologic agents. Discuss appropriate clinical management guidance for CDC Category A biologic agents. Background. Infections or infectious diseases are a continuing threat to all persons, regardless of age, gender, lifestyle, ethnic background, and socioeconomic status. In recent years, global concern has increased about epidemics and pandemics. An epidemic is when new cases of a certain disease in a given human population and during a given period substantially exceed what is expected based on recent experience. A pandemic is an epidemic that has spread through human populations across a large region, such as influenza, emerging infections, infections that are newly recognized as occurring in humans, although they can also affect animals and plants. Newly appearing in a different population than previously affected, though previously recognized. Newly affecting many more individuals or having evolved new attributes such as resistance or virulence features. And bioterrorism, the deliberate use of certain pathogens or biologic products by terrorists to influence the conduct of government or intimidate or coerce a civilian population. Health professionals need to be prepared to detect, diagnose, characterize, and respond appropriately to use of biologic weapons and to that threat of new and re-emerging infections. Key terms. It is important to understand the difference between an epidemic and a pandemic. An epidemic is defined by an illness or other health-related issue that occurs in higher numbers than would be expected normally within a country or region. A pandemic is an epidemic that has spread through human populations across a large region. 3 conditions must be met for a pandemic to occur. 1, a new disease emerges to which a population has little or no immunity. The disease is infectious for humans, and the disease spreads easily and among humans. In today's world, where anyone with any disease can travel around the world in less than 24 hours, an outbreak of a communicable disease in one country should be a concern for everyone in the world. Chain of infection. Portal of exit. How does the organism leave the reservoir? In emesis, a sneeze, diarrhea. Mode of transmission. How is the infection spread? Airborne, droplet, contact, vector mediated, fecal oral. Portal of entry. Infectious agents may enter the host through the skin. Mucous membranes, lungs, gastrointestinal tract. They may also enter through foreign bodies, such as medical devices. Example, Foley catheters, IVs, or feeding tubes. Susceptible host. The characteristics of the host that make him or her susceptible to a particular infection may include genetic factors. Immunity, vaccinations, age, nutrition status, or underlying medical conditions. For example, pregnancy, HIV infection, and many more. Bioterrorism and biologic warfare involve the intentional use of a biologic agent or biologic product to cause harm to humans and other living organisms. The distinction between these two is blurry and may be only a matter of scale. It is very difficult, if not impossible, for an intelligence service to detect the research, production, or transportation of these agents. It is equally difficult to defend against these agents once they have been released. Because bioterrorism may, by definition, is a criminal act that causes illness, both law enforcement and public health authorities have responsibilities for responding to the event. The CDC categorizes potential bioterror threats into three distinct categories: in decreasing severity and priority. Category A is the highest category and the one we will touch on here. Category A is the highest national priority. The bioterror agents listed in this category have the following characteristics: can be easily disseminated or transmitted from person to person, cause high mortality with potential for a major impact on public health, may cause public panic and social disruption, require special action for public health preparedness. Categories B and C are still important, but they pose less of a threat and are believed to be less devastating or likely a threat than category A. A complete list is available in your textbook or on the CDC website. A clinician who notes that something unusual is happening and seeks assistance for an explanation is likely to be first to detect a covert release of a biologic agent or emerging infectious disease outbreak. The most important aspect is for all healthcare providers to have a high index of suspicion for biologic events and to avail themselves of public health reporting. Each component of the public safety and public health framework can make its own unique observation that may contribute to the identification of a possible biologic event in the community. Sometimes it takes a combination of these to make the identification. EMS, along with dispatchers, may note an unusual increase in the number of calls to a specific geographic area or note multiple reports of the same type of complaints. Primary providers are key and help to recognize different patterns, such as new constellation of symptoms, increased numbers of common diseases, or common disease out of season, diseases affecting different populations, and many more. Public health professionals have the unique ability to monitor multiple hospitals, clinics, and laboratories simultaneously, and thus be able to appreciate patterns across multiple facilities. Medical examiners' offices may note an unexpected rise in mortality rate that is unexplained, which may be a clue of an attack. Other potential resources for detection are clinical laboratories, which may detect an increase in ordering of certain tests or unexpectedly identify a bioterrorism agent in a culture or specimen. BioWatch program is a system of sensors in major cities throughout the country that monitor for intentional release of biologic agent into the air. Epidemiologic clues of a bioterrorist attack. In addition to an increased number of patients, other clues that may signal a biologic disaster include an increase in unexplained death, unusual age distribution of the patients, unusual seasonality. Example, severe widespread respiratory illness during the summer months, an unusual manifestation of diseases. For example, new cluster of symptoms, inhalational anthrax, or the occurrence of animal die-off. Before we continue, it is important to mention a couple caveats when dealing with bioterror threats. The assessment and diagnosis of many of these conditions are complicated by the fact that one, most diseases present initially with generic, non-specific flu-like symptoms, fever, body aches, shortness of breath, and many more. Two, few to no specific diagnostic tests are available for the frontline provider in the emergency department, outpatient clinic, or pre-hospital. As mentioned, you need to have a high index of suspicion and consider bioterrorism to make the presumptive diagnosis. By the time a definitive diagnosis formally confirms your suspicion, many more people may have become infected. To add a layer of complexity, let me show you how tricky this process can be. Many natural diseases can present very similarly to bioterror agents. This table shows just a handful of such instances. As soon as suspicion of potential bioterrorism arises, the proper public health authorities must be notified immediately. This will set in motion many essential activities, including investigation into the case and source of infection, confirmatory test of the patients, public notifications, measures to control the outbreak, such as isolation or quarantine, mass vaccination, early treatment of known exposures, and identification of other potentially exposed victims. Infectious diseases, even bioterror agents, can be prevented and controlled by basic infection control, such as hand washing, PPE wearing, and equipment and surface cleaning. Infection control precautions required for any disease are based on the mode of transmission, whether that is direct contact, airborne, droplet, or vector-borne. If you are unsure what to wear, and you likely will be early on, wear the most protective available PPE. You may need the assistance of your local infectious disease specialist or public health office to determine the appropriate level of protection. Disease spread requires many actions on the part of the public health and the medical community. These can be divided into medical and public health interventions. Medical interventions include immunization, chemoprophylaxis, and infection control, such as provider infection control steps and patient actions such as respiratory protection, i.e., patients wearing masks. Public health interventions are arguably the most important to preventing secondary spread and also include infection control, sheltering in place, social distancing, risk communication and isolation, and quarantine. Now we will transition and discuss individual bioterror threats. The entire list of threats is lengthy and is beyond the scope of the BDLS course. However, we will touch on the highlights and the interesting aspects of the major threats, those in CDC Category A. These, as mentioned, are smallpox, plague, anthrax, tularemia, botulism, and viral hemorrhagic fevers. Smallpox. Smallpox is one of the deadliest diseases known to man. Smallpox was declared eradicated in 1980. However, stocks of smallpox virus continue to be stored in government facilities in the United States and Russia, and likely other unknown sites. Historically, the mortality rate for this virus is over 30%. Today, due to large numbers of immune-compromised and naive population, the mortality rate could be much higher. Smallpox is characterized by severe symptoms that occur before the development of a rash. These symptoms include high fever, generalized severe muscle aches, prostration, and delirium. About 2 to 3 days after symptoms begin, a rash begins to develop. Classically, the rash begins on the face, palms, and soles. The rash will scab over in 1 to 2 weeks. These scabs actually contain live smallpox virus and can be a reservoir for additional infections. It is important to differentiate from other pus-producing lesions, such as chickenpox and monkeypox. The diagnosis of smallpox is largely a clinical one, especially early on in the course before the classic rash appears. A provider must have high index of suspicion to make the diagnosis. The patient is contagious even before exhibiting the rash, so it is important to identify smallpox as soon as possible. Treatment involves giving the smallpox vaccine, which is effective if given within 3 days of exposure. Additional treatment is largely supportive with IV fluids, pain control, and eye irrigation. Animal studies have suggested that antivirals, such as cidofovir, may be effective in treating smallpox. Prophylaxis for exposed citizens and responders is the smallpox vaccine, again, if given within 3 days of exposure. Infection control requires airborne and contact gloves, gown, mask, eye protection precautions, and the patient should be in negative pressure room. Anthrax is caused by the bacterium Bacillus anthracis. Anthrax illness exists in 3 forms: cutaneous, inhalational, and GI. The cutaneous and inhalational forms are the most common and the ones most likely to be the result of a bilateral attack. The diagnosis of anthrax is initially clinical and again requires a higher index of suspicion. The inhalational form, especially, is a very quickly progressing severe respiratory illness. Multiple cases with similar symptoms that are unexplained should be presumed to represent a biologic attack. A chest X-ray may demonstrate a wide mediastinum in 70% of cases, bilateral infiltrates, and pleural effusions. These are not diagnostic, as many other processes may have these X-ray findings, but they certainly aid in your diagnosis. Early antibiotics are the treatment of choice. IV, ciprofloxacin, and digoxin are the standard treatments. But many other antibiotics in combination may be recommended. Prophylaxis for potentially exposed individuals include a 100-day course of oral ciprofloxacin. Anthrax is not known to spread from person to person, so standard precautions are recommended. Pneumonic plague. Pneumonic plague is caused by the bacterium Yersinia pestis. Plague is endemic throughout the world with multiple animal reservoirs. Did you know that the major reservoir for plague in the United States is the prairie dog? Natural outbreaks occur occasionally, particularly in the southwestern United States. Natural outbreaks typically occur by transmission of the bacterium by fleas or biting flies. These result in bubonic plague, involving skin lesions and large swollen lymph nodes, which is distinct from pneumonic plague. Plague is thought to be a disease at high probability for use as a bioweapon. The bacterium is easy to grow in large quantities and relatively easy to disseminate, especially as an aerosol. Plague spreads from person to person and has a high mortality rate. Symptoms include the abrupt onset of flu-like symptoms, including high fever, chills, cough, shortness of breath, chest pain, nausea, and vomiting. This evolves into rapidly progressive pneumonia, respiratory failure, and overwhelming sepsis. The diagnosis of pneumonic plague is clinical. Your high suspicion can be aided by a chest X-ray with patchy fluffy infiltrates and positive blood and sputum cultures. Treatment and prophylaxis for exposed individuals are antibiotics. Patients with pneumonic plague may need to be on a ventilator for a prolonged period and will need multiple IV antibiotics. Prophylaxis is with oral ciprofloxacin and digoxin. This disease is highly contagious. Droplet precautions must be strictly adhered to. Common practice for prevention of plague outbreak in the 1700s rings true today as well. Most people, when confronted by the plague, follow the collective wisdom to flee immediately, stay far away, and be late in returning. Botulism is caused by the toxin of the bacterium Clostridium botulinum. In that sense, the process is more like a chemical exposure than an infectious disease. Natural outbreaks occur occasionally. The most common presentation will be an infant who was fed honey that was tainted. The toxin of botulism is one of the most poisonous substances known to man. In a biologic attack, botulism will be spread via the aerosolized route as a toxic contaminant of food or water. Symptoms include the gradual onset of a bulbar palsy, facial and eyelid drooping, difficulty to speak and swallowing, trouble handling secretions, and dry mouth. Multiple cranial nerves must be involved for botulism to be the cause. Symptoms progress to weakness and paralysis of skeletal muscles, and eventually complete paralysis of the diaphragm, which causes respiratory failure. The effects of botulism occur with no fevers or mental status changes. The diagnosis of botulism is clinical. The features of the conditions are distinct. However, mild cases can easily be confused with other medical problems. The diagnosis can be confirmed by a toxin assay performed by the CDC or some state laboratories. The treatment is largely supportive since the diaphragm is paralyzed. The patient will need to be on a ventilator for a prolonged period until the toxin wears off. This could take anywhere from weeks to months. An antitoxin is available and can be obtained from state health departments or the CDC. However, the supply of antitoxin is severely limited and is designed for single episodic cases. As botulism is not contagious, only standard PPE is recommended during the evaluation and treatment of these patients. Tularemia. Tularemia is a bacterial infection caused by Francisella tularensis. It is endemic in animals in North America, Europe, and Asia. Sporadic natural cases occur from ticks, biting flies, and infected rabbits. Multiple countries have a history of weaponizing tularemia for biologic warfare. The most likely route will be via an aerosol. Symptoms include acute febrile illness with prostration and regional swelling of lymph nodes. Pneumonia occurs in 80% of cases. The diagnosis of tularemia is clinical. It does not have any symptoms that are pathognomonic by themselves, but a constellation of fever, prostration, conjunctivitis, lymph node swelling, and pneumonia is highly suggestive. Multiple lab tests can be sent, 4 to 8 in diagnosis. A gram stain may show gram-negative Coccobacillus. Blood and sputum cultures are diagnostic but may take days to weeks. Additionally, labs can do antibodies testing or PCR. Treatment is with IV antibiotics, streptomycin and gentamicin. Prophylaxis for exposed individuals is with ciprofloxacin and doxycycline. Viral hemorrhagic fevers. Viral hemorrhagic fevers are the diseases in bioterrorism that strike fear in the hearts of everyone. This is largely caused by urban legend and popular books and movies. This class of diseases encompass multiple strains of RNA viruses, most commonly the arenaviruses and filoviruses. They are typically named by the area in which they were first discovered. Hence, the name such as Marburg, Lassa, Omsk, and Machupo fevers. These have been weaponized by several countries. The fatality rate is dependent on the virus, but may be as high as 90%. Symptoms also depend highly on the specific virus. Symptoms range from flu-like symptoms, joint pains, and small rashes to progressive diffuse bleeding. Blood and vomit, stools, sputum, mucous membranes, and urine, and hemorrhagic shock and death. The diagnosis of VHF is largely clinical. There are special labs available at the CDC to assist in diagnosis. The recommendation is that a clinician presume VHF in the right clinical circumstances in a patient who is severely ill, has a fever, and is bleeding from 2 different sites. Treatment is largely supportive, though ribavirin may be a therapeutic option. There is no prophylaxis for exposed persons at this time. Vaccines are in development. VHFs are extremely contagious. Patients must be in strict isolation and negative pressure rooms. Triage and treatment summary. The key point is recognition. This is based on any pattern outside the norm triggering a reaction in all healthcare providers. Depending on the situation, as a minimum, this is followed by discussion with local public health officials. You will undoubtedly have noticed some common themes among these diseases. Nearly all of them present early on with non-specific flu-like illness. The diagnoses are largely clinical, with the assistance of specialized confirmatory blood tests that will not be available in the first couple of days. Most of these diseases have no silver bullet for treatment. Many require broad-spectrum antibiotics and supportive care. Vaccines are available as an option for some if given early enough in the course. When a patient has symptoms from a potential bioterror source, responder safety and the prevention of spread of the infection are paramount concerns. Appropriate PPE is mandatory and will vary by disease process. Having a specific vaccination for a biologic agent is complicated by the availability of it in a timely fashion. Initial effective dose administration and subsequent dose requirement to be effective, as well as the many logistical challenges and operational challenges with a successful mass vaccination event. This is why that even though some category A agents have a vaccine, these complicating delivery and distribution issues still cause it to be a significant national biologic threat. On a broader note, having sufficient quantities of PPE, compliance with their use, etc., make PPE an ever important provider safety issue of concern. Prophylaxis, should it need to be administered to an at-risk provider group, presents may challenge as well. For example, ensuring compliance is extremely difficult, especially when prolonged medication courses are required, as well when side effects, even if mild, are anticipated. Lesson summary. Biologic disasters require observation for both clinical and epidemiologic clues. There is increasing global concern about the possibility of bioterrorism. Medical and public health professionals play a key role in preparedness, early identification, and intervention. Any questions? This is the end of the presentation.